Welcome to this essential guide on HbA1c, focusing specifically on the latest NICE guidelines for primary care. Whether you are a GP, nurse, or trainee, this video will provide a clear, clinically accurate, and practical understanding of this key diabetes marker. Let's start with the basics. What exactly is HbA1c, and why is it so crucial in managing diabetes? HbA1c stands for glycated hemoglobin. It reflects the average level of blood glucose over the preceding 3 months by measuring how much glucose is attached to your red blood cells. Because it gives a longer-term picture than a single blood glucose reading, HbA1c is the standard measure for diagnosing diabetes, assessing glycemic control, and guiding treatment adjustments in primary care. Now, let's look at how HbA1c is measured and the critical diagnostic thresholds set by NICE. HbA1c results are primarily reported in mmol per mole in the UK. Understanding the conversion to the old percentage unit is useful. For instance, 48 mmol per mole is roughly equivalent to 6.5%. According to NICE, the diagnostic range for prediabetes or non-diabetic hyperglycemia is an HbA1c between 42 mmol per mole and 47 mmol per mole. A diagnosis of type 2 diabetes is made when the HbA1c is 48 mmol per mole or higher. This threshold applies to individuals without symptoms. If symptomatic, a single reading may suffice. Diagnostic thresholds tell us if someone has diabetes, but treatment targets guide us on how well they are managing it. For most people with type 2 diabetes starting on lifestyle interventions alone, the initial target is 48 mmol per mole. Once on medication, the target is generally lowered to 53 mmol per mole to prevent complications. For type 1 diabetes, NICE recommends a general target of 48 mmol per mole or lower without causing problematic hypoglycemia, reflecting the need for tight control in this cohort. For frail or elderly patients, targets must be individualized. The priority shifts to avoiding hypoglycemia and minimizing treatment burden, meaning higher, less stringent targets may be appropriate. It is crucial to know when an HbA1c result may be unreliable and should not be used for diagnosis or monitoring. HbA1c relies on the lifespan of red blood cells. Conditions like severe anemia or hemoglobinopathies, such as sickle cell or thalassemia, alter red cell turnover, making the HbA1c measurement inaccurate. In periods of rapid glycemic change, such as during pregnancy, acute illness, or after initiating insulin, HbA1c won't accurately reflect the current blood glucose. Use alternative measures like blood glucose monitoring instead. NICE generally recommends monitoring HbA1c at least every 6 months for most patients, or every 3 months if glycemic control is poor or medication is being changed. The raw number is just the starting point. Effective primary care requires skillful interpretation and awareness of common pitfalls. When interpreting a result, look at the trend. A single improved reading might reflect a recent effort, whereas a consistent drop over time suggests genuine progress. Achieving and maintaining HbA1c targets is directly linked to reducing the long-term risk of microvascular complications. Aim for tight control when appropriate. Individualize care for the vulnerable, and know when the test isn't reliable. Thank you for watching.